Good morning, everyone. This is Beth Shibley, and I'm coming to you for another conversation, Caregiver Conversation through Sunflower House, a program of Aging Matters in Brevard. And this morning I have Jital Patel from Coastal Occupational Therapies with me, and we're going to talk about strokes today. It's something that's kind of, I think Jital and I talked about it a little bit. I've had my mother-in-law's had a few episodes, and my grandmother had a huge stroke very early in life. So I'm interested to hear more about the physiology and the treatments and stuff. And I thank you so much for coming, and welcome.
Of course. Thank you so much, Beth, for having me. Okay, so we will kind of get right into this. I will share my screen. So what we're going to be talking about today is just strokes, the basics of strokes, and recognizing symptoms, like you said, the physiology, the therapies, the resources, everything that's available, just to kind of give everyone an idea of what it is that, entails a stroke. So the first thing is we want to recognize the first two big associations we have are National Stroke Association and the American Stroke Association. They have a whole slew of information online. You can just Google them, and on their websites, they tell you everything that you need to know. So the first things, the three things that they really encourage, and the point of this presentation is we want to be able to stop and recognize the primary and secondary stroke factors and the risk factor managements. What do we need to do to manage stroke to either prevent or stop, or delay them from happening? The associations also encourage increasing awareness of stroke and how to act fast. The FAST is an acronym which we'll go over a little bit later, and to increase recognition of and response to stroke symptoms and spread hope about recovery from stroke. Okay. They also really focus on being stroke smart. What that means is how to learn how to reduce the stroke risk, recognizing the symptoms, and respond at the first sign of stroke to call 911 immediately.
Yeah, absolutely crucial.
Exactly. And we'll go through details about how do you recognize all of these things. So to get a little bit of an information on strokes, so everyone kind of gets an idea, stroke is the third leading cause of years of life lost. It's a leading cause of death and disability in the United States. And like I said, the third leading cause across the world.
That's just amazing that it's that prevalent.
Exactly. And if you look at the numbers right here in the United States, those are big numbers. Mm-hmm. A total of almost 5.8, almost 6 million prevalent stroke cases. And this is according to our National Institute of Health research from 2020. So this is all up-to-date information on here. It's a costly disease from human, family, and the societal perspective. It is starting from a human cost perspective, it's the leading cause of death and disability. About almost 800,000 Americans suffer strokes each year, and of that 134,000 deaths each year. So it's very serious. We really have to take a look into what's happening and why strokes are happening.
Yeah, one of the things that that really strokes have such a huge outward effect on your everyday life. That just your ability to do things, your activities of daily living, it's so much, very much impacts that, even I think more than some other, comorbidities that you could have. Not saying that other things don't affect your life, but having a stroke is just vital to a quality of life, and being able to, preventing strokes is just vital to it.
Right. And exactly right. There's so many cognitive and physical changes that happen to stroke survivors. It's incredible, and because of that, there's a lot of loss of not just, loss of life when people do unfortunately pass away, but just physically you kind of, and we talked about depression, post-stroke as well. So there's a lot of factors that take into play when someone is recovering from a stroke, and it affects the caregivers, family members, and friends, and it's really tough.
Mm-hmm.
Okay, so what is a stroke? Okay, so there's two different types of strokes, and this is important because, you know, you'll just hear people say, well, I've had a stroke, or this person had a stroke. Well, there's two different kinds, and both of these have different impacts on what happens to you post-stroke. So just generally, a stroke is a sudden brain damage, okay, and it's a lack of blood flow to the brain caused by either a clot or a rupture of a blood vessel. So the clot is called ischemic stroke, and that makes up of about 87% of all strokes. So you can kind of see here, there's two different types of clots. There's an embolic and a thrombotic. So you can kind of see there's a little ball here, there's a clot that travels, that kind of moves around. And then this is where, right here, and you see the buildup over here that loss of blood circulation, so you have less blood flowing through.
So with the thrombotic, is that often caused? One of the sort of reasons why you might be at risk for that could it be like high cholesterol or just the basic, you know, issues that people have with buildup in their veins?
Absolutely, yeah. It's one of the causes. And again, you know, the research with doctors, they would probably have a little bit more information, but that's exactly it. You know, diet, and your environment and your physical well-being,
Yes. And your
makes a
genetics.
difference. Yeah, exactly. Yeah, absolutely. Because, you know, sometimes you can live a very healthy life and do everything right, you know, exercise and eat well, but sometimes you end up having a stroke.
You know,
And I've personally known people that it's happened to. So yeah. Or, you know, weakness in the face, you'll notice a lot of times one of the first things you notice, it's the drooping of the one side of the face.
right.
Any of these symptoms that you observe, you want to call 911 because every minute matters.
And I think it's really when you're talking about just the sudden confusion and trouble talking, and if they don't have that it can be really easy to miss those symptoms unless you're paying attention. You know,
Right.
it can take a little while if you're not seeing the traditional drooping or difficulty walking, but they're starting to be confused and stuff. So,
Right. Yeah. And this is what I was talking about, the FAST. FAST is an acronym that we all want to learn. Fast. You want to act fast. And you want the FAST stands for F for face. So you want to look for one side of the face if it's drooping. A for arms, if there's arm weakness, all of a sudden you'll see one arm kind of just hanging and a little flaccid, speech difficulty, and T for time. So you notice any of this is time to call for an ambulance.
Wow.
Strokes, they strike fast, and you should too. So I really like this. I've actually printed this out in a lot of the clinics that I work at. You know, we kind of take them up just for caregivers and family members to be aware. A lot of times if someone's had a TIA, and that's one of our next things we'll talk about. It's also another type of a stroke. Those are precursors to a larger stroke. So it's important for people, family members, to be aware. So TIA stands for a transient ischemic attack. And that's a warning sign of a future stroke. Up to 40% of the patients that have TIA, they're known to have a future stroke. So the symptoms of the TIAs are the same as a stroke. There's nothing different. So what we talked about here to look out for is the same for TIA. We don't know outwardly what kind of a stroke it's happening inside our bodies, but we know the symptoms to look for.
Well, although I think I have, like I said at the top of this conversation is I've got family members that have had TIAs, and in the lay world, a lot of times they're called mini strokes.
Yep.
And what we have noticed is that when she has them, it's a little more subtle than an all-out major stroke. So sometimes it isn't even until a little later on that we've gone, oh wow, the other morning when she was so confused, we wonder whether or not it might have been a TIA, because right. the symptoms are a little less dramatic, I think, even though they're the same.
Right. Yeah. Yep. And you're right. The symptoms are, like you said, a little less dramatic, and they are the same. The thing with the TIA is that they can resolve in minutes or hours. Mm-hmm. So a lot of times that, people that do suffer from a TIA type of a stroke, they may not have any symptoms afterwards.
Right.
Maybe very mild weakness in one extremity or the other. But the symptoms resolve within minutes or within hours.
Exactly, and that's been the case with my loved one. Is that
mm-hmm.
Sort of it isn't until it comes, it kind of comes back that we go, maybe that's what that was, and so it's sort of an alert thing.
Yep, exactly.
And sometimes it's very quick.
Oh yeah, very quick, and my dad, for instance, the same thing with him. Sometimes we wonder, well, I would be like, well, did he just have a TIA? Because it's very sudden. To some people, it's very sudden, So it's always important to seek medical attention. You want to call your doctor and, let them know that, hey, certain family member, you're noticing these symptoms that happen, and they're able to check you out, run an EKG and.
That's one of those things I think, Jital, that it's really important to highlight is the fact that at least from my point of view as a caregiver, I've and family members of mine that have been caregivers, if somebody has had a TIA or you suspect they've had a TIA, even though it's self-resolved, you're right. You still got to make sure that has been addressed, because it could be a precursor to a bigger problem. And sometimes I think that it can be hard to talk somebody into going to see their doctor if they're no longer having the problem, sort of like the ostrich philosophy of healthcare, where, it's gone. It was a problem for, it was only a couple of minutes while I was making my coffee, and now I'm fine.
Oh yeah. So I can't tell you the number of clients that I've seen throughout my years as a therapist that I've heard the same thing. And then unfortunately, I am seeing them again is because they did end up having a bigger stroke, but they'll tell me their stories, and most often than not, they will say, I wish I would have addressed this sooner. I wish I would have gone to my doctor, checked up on my blood pressure, that one time that I wasn't feeling well, I didn't go.
Right.
So I almost always hear that. That's why this is so important that, not only do we learn the symptoms, but also to recognize that it may or may not be. We're hoping it's not, but any off feeling that you may have, and knowing that you may have comorbidities, high blood pressure, diabetes, and any of that, you want to just let your doctor know. At least that way they're aware. So in case if something does happen, they know that, hey, they might have had a TIA, so let's check up on this.
Well,
you know?
sure, and there are different tests that doctors can do, I think, to be able to evaluate your risk factors, and if they think that if you've had several different TIAs, they might want to schedule some testing to be able to see if there's some things going on with either,
Right.
deep vein thrombosis or which are the blood clots. I think mostly in deep vein thromboses, most of the time I've heard of them have been like in your legs.
Yep. So yeah, the DVTs there, that's what it is, a deep vein thrombosis. A lot of times with therapy, when we are told that a client has DVTs in their legs, we don't do any therapy because we don't want the DVT, the clot to travel,
Right.
right? We don't want it to travel up and into your heart or your lungs and cause a stroke or anything. So yeah, that's also a lot. And you'll notice there's some ways to look out for a DVT when someone complains of lower leg pain. If you put your your hand to their leg to kind of feel for temperature, it's almost always warm. So
Mm-hmm.
one part of the leg is warmer than the other, and a lot of pain. So that's when you'll know to,
Yep.
yeah. So you
Just
want to
feels
check on that.
angry. It just feels really angry. That's what I used to put
Yeah.
it on. It's like, wow, that feels really angry right there.
Yeah. And on this slide, perceptions of stroke, myth versus reality, this is kind of like what I was talking about, the clients that I've seen in
Yeah.
the past. A lot of times this is where their mindset is,
Mm-hmm.
they just think that, well, it's not preventable, if it's going to happen, it's going to happen, which is not true. 80% of the strokes are preventable.
Mm-hmm.
Um, they also think that they cannot be treated. Well, stroke requires emergency treatment. That's when we talk about the fast. You want to act fast because there are ways that you can get that treated fast. And they don't strike only in the elderly, like you and I talked about. You had a 34-year-old person that you knew, and I knew an 18-year-old. So it does not only strike the elderly. It's, anyone can have a stroke.
Absolutely. My grandma, when I was talking about before earlier on, I said she was in her mid 40s and it was a severe stroke. It wasn't just a TIA, it was a significant stroke. She
Right.
had to learn how to walk and talk again. She was a smoker, so I think that probably was, that was kind of more prevalent back in the 60s. So, you know,
Yeah. It is. It's really unfortunate, like you said, if the smoking and is a big part on preventing stroke from happening. And the other thing is, well, stroke happens in the heart. It's a that's a myth.
yeah, well, that's,
um,
that's a heart attack.
yep, exactly. And they're two different things. Stroke is a brain attack. Yep, because like we talked about, it's an ischemic or a thrombotic, embolism in your brain.
Mm-hmm.
Um, stroke recovery ends after 6 months. No, it does not. As a therapist, I can tell you that sometimes it takes years, sometimes it's a lifelong recovery process. And
And you're
that
seeing
means
improvement, right? I mean, you can show improvement after, longer than 6 months. I think that
ab-
you're right.
absolutely, yeah.
I mean,
The-
that's,
just like acting fast on a stroke, recovery, it has to be immediate as well.
right.
We say that therapy needs to happen almost immediately post-stroke. Now, depends on the severity of the stroke. This is where recovery can last a lifetime. If your severity is just, you've been really debilitated, you're hemiplegic on your left or right side, it takes a longer time. But the key is that you want to start right away. You want to start doing your therapy right away.
Mm-hmm.
And there's different types of therapies available. We have a whole list of them that, we'll talk about. But on that note, another way, we talk about a brain attack is if you have a left side of a brain and a right side of the brain. If you have a stroke on your right side of the brain, your left side of the body will be affected, and vice versa. If you have a stroke on the left side of your brain, your right side of the body will be affected. So it's always that crossover. And then there's also strokes that happen at your brain stem, kind of, smack in the middle.
Mm-hmm.
And so each side of the brain, that wherever you have the stroke, the symptoms are different.
Right.
They're very different. So, depending on the side of the brain the stroke happens, sometimes people lose their ability to, they have aphasia.
Mm-hmm.
So they have difficulty speaking. They know they know what they want to say, but the output is not coming out, right? They don't
So
know
they can't
words
find
aren't
words.
coming out. Exactly. The word finding difficulty. A lot of times you just kind of lose the ability to even just speak. And other times they're just like random words being thrown at you. There's no sense of it whatsoever. Everything is working right here, but there's no sense coming out.
I will say that I remember my grandma when she stayed with us, my grandmother when she stayed with us, I mean, she was not a woman to have particularly blue language, but for quite a while when she was home, she sounded more like a sailor on shore leave than she did my grandmother. There were some words coming out of her mouth that were not particularly something you'd say in church.
Yeah, and I'll tell you a really good story. When I was going to grad school for occupational therapy, I was doing field work at a stroke clinic, and we had this one woman. She was elderly, had a stroke. It was a pretty severe stroke, so she was debilitated in the wheelchair, did not speak. She just kind of literally the only words that came out of her mouth were yada 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 yada. So all day long she'd be in the wheelchair, and that's what she was saying. After tracking down her family members and everyone, we kind of found out when she was younger, she was a musician. So she was trying to say those notes in her head.
Oh, wow.
Yep. And then, so the real cool thing was, someone one day started singing in the clinic, in the, in the room.
Oh.
And then they were singing happy birthday to someone, and she joined in.
Oh my gosh.
So I was at the clinic for, 2-3 months, and I've never heard her say anything else except for that one day. Someone was singing happy birthday and she joined in. All of a sudden, she's sitting there singing happy birthday to you. And like the first words we ever heard from her, and it was so incredible because the part of her brain where the stroke happened, the music part of it was still, it wasn't affected. She was able to sing.
Able to sing.
Yep. So all the songs that we learn as a child, she was able to sing all of those. So upon prompting, she could not, but if you sang with her and if you just stood next to her and started singing, she would join along with you. Wow. It was so incredible. So our brain is such a wonderful, amazing and a mysterious thing that there's so many, not just rehabilitation, but our brain is neuroplastic, so we're able to regenerate.
Right.
A lot of the habits and work habits. So that's where therapy comes into play, where you want to make sure that you address it as soon, because we don't know what all is going on in there until we start learning about it.
That's one of the things about specifically about the brain, I think, as an organ. I mean, we can figure out the sort of like see what is happening, but why it's happening and how things happen. I mean, you can, in their different machines now, you can see where there are certain areas that light up. So functionally, you can tell where things are, but exactly what's making it happen and what's actually happening, like what's causing a memory or what's, those parts, those are still deep mysteries. I mean, how is it that's happened? We can't fully explain it. We can show you where it is.
Right.
But we can't fully explain that there's a gap there,
Mm-hmm.
And you're
Absolutely.
right. It's really one of I think the most fascinating organs we have.
Absolutely. And I the way I explain it to a lot of my patients is, think of it, when you have one of the symptoms as a hemiplegia, and they're trying to make the movement and movement's not happening. I explain to them, I said, think of it as you're trying to jumpstart your car, mm-hmm. right? You're providing this input, but the action is not happening. So it's you're telling your brain, hey, move my hand. You're sending that input, but there's no motor control, right? You're trying to fire your nerves and you're trying to send the signals from your brain, but the action's not happening. So it's like that. You constantly have to bombard your brain and your extremities, your motor neurons to fire to cause an action. And that's just one part of it. Like you said, there's so much that happens, which is I'm a big supporter of our stroke associations, our local stroke groups here, because education is so important. People need to be educated about what all is happening. You know, they're doing great research to find out other methods of treatment too, and they've come up with a lot of really really neat treatments that you can do.
So one of the things that you said before, a phrase that you said before, was neuroplasticity.
Mm-hmm.
Talk to me a little bit about what that is. Tell me more about neuroplasticity.
So you're able to, with neuroplasticity, you're able to re, um, and we may have to edit this. So I think with neuroplasticity, you're able to regenerate your nerves or your neurons, if I'm not mistaken. Pretty much is that your brain is able to relearn. Your brain is able to relearn what's lost due to a stroke.
Right.
So like we said, movement of the arm or leg, or you're able to speak. You're able to retrain your brain to do that again. One of the therapies that I really like to use is mirror therapy, and I'll show you what that looks like. And that's what it does. It kind of tricks the brain into thinking that a part of your arm or leg is moving, and it's sending signals to your brain to say your left side is not moving. It's sending signals to that side to teach it to move again, to teach it to work again. So neuroplasticity is just that your brain has the ability to relearn those
Yeah,
lost deficits.
what I think about when I think of the phrase neuroplasticity, I think about if I'm driving somewhere and there's an accident in front of me and I've got Google, I've got one of my GPS on my phone, it'll give me an alternative route. So
Right.
it feels like that's part of neuroplasticity, is the brain. You've got a damaged area that's not going to work, but the brain can work around that to give you it's a workaround.
Yep. And here's a better definition of it. So it's the ability of the brain to form and recognize the synaptic connections in response to an injury. So it's able to reform those connections again. Those synaptic connections. You need to have the synapses. Due to a stroke, the synapses are broken down or injured, and your brain has the capacity to reorganize and reorganize the connections.
Yeah, make new ones, right? And a new road and a new way to be able to do that. So
exactly. And like I was saying, as far as the associations go, they do a lot of research, but at the same time, we have to understand like the cost of the stroke, which is the reason this is so important, is because you and I, we have, through education and all sorts of resources, the understanding of what we can do to prevent a stroke, because the cost of stroke is incredibly high. So there's estimated direct and indirect cost of stroke is $103.5 billion. Okay, so I'll kind of briefly explain the direct and indirect. So direct costs include your expenditures from the hospitals, emergency room, clinic visits, medications, home health visits. Those are all the direct costs. Indirect costs depend on employment, loss of employment, wages, missed work days, productivity due to death. So these two combined, $103 billion. So 2/3 of this annual cost is involved with stroke patients. 2/3 of this is indirect cost. So
I believe that. Yeah.
Yep. So 2/3 of this is about $30 billion. So $30 billion are lost, our indirect costs. And then remember, we said indirect cost is missed work days, employment, wages. That's a lot.
Yeah, that's huge. Yeah.
Yep. Loss of productivity is heavily concentrated in the economically productive age group.
Right.
Like we talked about, the age group, people having strokes is getting younger.
And it's not even necessarily just when you talk about indirect costs, the loss of productivity for the particular person. It could be the loss of or reduced employment for the people they live with. If you've got all of a sudden your spouse has had a stroke, you very well might need to take some time off or modify what you do for a living to be able to help take care of that person. And that's an indirect cost that's, so it doesn't just affect the person necessarily that's had the stroke. There are all their loved ones and all of their circle,
Yep.
that it can affect.
Absolutely. Yeah. I'll have family members flying down every
Mm-hmm.
other week if someone had a stroke, but they have their kids, they're living in different states. So they're now taking
Right.
turns, taking a week off and coming to this stay with the parent, leaving. So another sibling will come. So they're losing their time at job. And
Right.
then at some point or another, either the patient will move somewhere else to be with their kids, or the kids will move down and stay with the parents. So
And there's
there's
all
a
those
whole change.
costs associated. Yes, absolutely.
Absolutely. So, these, the number is really important because this gives us a greater emphasis on stroke prevention strategies, what you and I can do to prevent stroke.
Well, and the whole phrasing of, an ounce of prevention, and how much, does the research, how much, research, how many resources and how much resources, financial resources are we putting towards stroke, understanding it better and preventing it better,
Yep.
would that not make a huge difference in the outlay of direct and indirect costs afterwards?
Right. Yeah. Yeah, it's really important. And, we talk about this. Well, how do you prevent stroke? Just exactly what we said. So the National Stroke Association, they recommend that you follow these guidelines to help reduce your risk for stroke. Okay. And what are these guidelines? Right here, all of these over here. So one, if you've had blood pressure issues, know your blood pressure. Have it checked at least annually. If you have high blood pressure, as a clinician, I would say check it regularly.
Mm-hmm.
Keep a diary, a notebook, that you check what time of the day. And anytime you go to a doctor's visit, show them that. If there's something that you want to, of concern, you definitely want to show them that, hey, this is the blood pressure I've been getting every day. It's a little higher than normal, especially this week. So they're able to work with you to help you control it.
Yeah, there are, 30, 40 years ago, back when I was well, not really quite a child, but I was, blood pressure cuffs were something that just happened in doctor's offices and nursing and hospitals. If you were a nurse, you had one, but if in the lay world, you didn't necessarily have one 40 years ago. Now they're not super expensive. And also, even if you can't necessarily afford one, they're at a lot of the pharmacies and Publix, and you can just go and stick your arm in, and it, while you're waiting for something to, whatever it is, you're waiting to get your prescription filled in, or, there's no reason why people can't have that done on a really regular basis.
Absolutely. Oh yeah. They're not expensive. You can pick it up at any pharmacy. And like you said, I check mine every time I go to Publix.
Right.
While I'm waiting either, at the pharmacy or something, I just go in there, stick my arm in there and check my blood pressure.
Right.
My blood pressure tends to run really low, and that's just normal for me, but I like to get it checked because of that.
Well, and it's also good to know if it runs low, because then you're more at risk for some other things. If you have a low blood pressure and you don't know it, you really have to pay attention to, to being dizzy when you stand up, to paying, all of those things, to being, more deliberative about,
Yep.
not jumping up real quick,
That's right.
Yeah.
Yep. And some of the other things are, important to know is if you have atrial fibrillation, AFib, that's an irregular heartbeat. And if you have it, you'll know it. You'll definitely know it. Your heart will, it'll feel like it's skipping beats. It's working really hard.
Mm-hmm.
A lot of times people end up having pacemakers to control that, to have that regular heartbeat. So if you have that, if you feel like you're just, your heartbeat's not normal, you can check your pulse.
Mm-hmm.
You can check it on your wrist, or you can check it right over here at the artery. And if you feel like it's not normal, you definitely let your doctor know. If you drink alcohol, that do so in moderation. No one's saying you have to stop drinking completely, but if you do so in moderation.
What's
and
moderation? Do you know? Can you tell me what you think of as moderation?
I don't know, honestly. Like I would say, if you're drinking every day,
Mm-hmm.
4 to 5 drinks a day every day, that may be a little much.
Yeah. I think what I've heard is, no more than a handful of drinks a week, or no more than one a day.
Right. Yeah.
Not like a huge, like, you know, like little drinks, like serving size
Yeah,
matters too.
exactly. Because you say one, someone's going to come up with a huge bottle and say, that's my one.
Glasses, yes.
Yeah, and exactly. So you have to know your own moderation. So what's in moderation for me may be completely different for someone else because our body
That's
weights
true.
and sizes are different too.
That's true.
So, but yeah, essentially the point is don't overdo it
Right,
because in combination, if you have high blood pressure, you have diabetes, and you're drinking alcohol, it's just pretty bad combinations.
right.
They're not going to help you, you know?
No,
Uh,
probably not. Probably
yeah.
not.
Cholesterol is also very, very important. If it's high, you have to talk to your doctor to help you control your cholesterol. You
Right.
can exercise and change your diet. You know, that's something that's it's preventable. You
And
can
there's
reduce
medications.
cholesterol numbers.
You know,
Yep.
some of it's genetic. I mean, I know that there are some people that have, not really great diets at all, and they don't seem to have it, then they don't seem to have any cholesterol issues. And other people really work on it, and they still struggle with their cholesterol, and they have to, and they really, some of it's just genetics. You know.
Right. My parents are have been like that. They're both many years ago when they started doing the regular follow-ups with doctors, they were told that they were both diabetic and they both had high cholesterol. Diabetes runs in our family. Um,
Mhm.
but initially they were just like, oh, well, it runs in our family. But that's not the case. You can still manage and control that.
Sure.
Uh, so yeah, we've educated them a lot on proper diet, exercising regularly. They
Mhm.
live up north, so they get a lot of snow. So during the winter months, they don't get the exercise, and that their excuse is, well, it's snowing outside. Well, then we'll get you a treadmill. So we did get him a treadmill.
Or a shovel. They could go out and shovel. They could shovel their snow.
Right. Yeah. But over time, I'll be honest, they were off of both of their medications for high cholesterol and diabetes. Their numbers have been normal for the last so many years.
And that's great. And that's one of the things about just understanding if it runs in your family, that's really more of a reason to pay attention than less.
Right.
Because you have to be
Right.
sort of aware that it can happen and you have a tendency towards that direction. So,
Right.
yeah, you have to be more
And
vigilant.
yep. And it's not to say that it's the same for everyone. I'm not saying that, you
Right.
as long as you make your exercise and your diet that you're going to completely undo this, but it's a good starting point. You can at least lower your numbers. When you do have your next blood check, blood work done, your numbers will be a little lower as long as you follow the routine.
And
That's,
a lot of times you can do that. When you do that, you can have you can lower your medication, even if it's not totally. Even though you maybe can't totally get off of your medication, you might be able to reduce the dosage,
right.
be able to reduce the number of meds you have, and that's always a good thing.
Yeah, absolutely. Yep. You're exactly right. And then content, a lower fat diet. If you're eating a lot of food from outside, a lot of takeouts and all of that, they have high sodium content. So you want to be careful about that. Read your labels. Sometimes it'll say, low fat, but it's not necessarily low fat. It went from, full fat, like half or something, and they'll say it's low fat. So just kind of read your labels. Nutrition, how to read nutrition labels. There's a really good YouTube video done by a nutritionist, and they kind of teach you on how to read your labels. It's so important because some of those can be, not so, they're not so honest in advertising. So
Yeah,
you have to be
not so intuitive. Yeah.
yeah. So just have to be careful what you're taking in. Certainly circulation problems, definitely, again, along with blood pressure, cholesterol, let your doctor know. You want to let your doctor know if you're seeing them regularly, any of these issues that just give them a heads up that they can, help you manage these symptoms. Okay. So your stroke awareness. The other thing that the association really recommends is that you learn stroke symptoms and how to respond to symptoms by calling 911. And we kind of talked about that a little bit earlier. FAST, the acronym FAST, FAST, looking for facial drooping, arm weakness, slurred speech, and T for time. You want to act real fast. Okay. So we talked about also that there are treatments. Stroke, it's not. It's preventable and it's treatable. So we talked about this. When someone has an ischemic stroke, which was a blood clot, they use what's called a TPA, the tissue plasminogen activator. This is a clot busting medication, and they say that if you act fast and get the person to the hospital within a set amount of time, and I think they say it's within an hour.
Right.
I could be wrong about this. About an hour, and if you get there, they are able to administer the TPA to bust that clot.
Yeah, and it's called the golden hour, I think. I think it's called the golden hour. Yeah.
Yeah, I think so. And that's why, like I said, time is key. Time is of essence, because if you pass that time limit, they're not able to administer TPA. They have other devices called the Mercy Retriever. Those are devices that actually go in and retrieve the clot. If you're having a hemorrhagic stroke, now this is a brain bleed versus a brain clot, they can go ahead and clip or coil the aneurysm, or maybe surgery is required to physically remove the clot. So there are treatments that are available, and they're doing so much more research to find out other treatments that you can do. Say someone comes in and they're not able to administer the TPA, they're working on other treatments that they're able to perform.
Mm-hmm.
Okay, so recovery, some numbers for recovery. I muted myself, there we go. Just to give people some hope and know that there is hope. Okay, 10% of the stroke survivors recover almost completely. Now the number may not sound incredibly high, but it is. You do recover almost completely. 25% recover with minor impairment. This is not just, you had a stroke and you just automatically recover. It's through a lot of therapy. Right. So not just going on therapy, there's all sorts of other therapies involved, and that may just include, being at home with family, mental support also. Everything, plays into your process. 40% experience moderate to severe impairments, especially requiring special care. Right. Yep. This number here is a little scary, versus 15% die shortly after the stroke. That keep in mind that those people may have other comorbidities. They may have other underlying issues, age related or whatever, that, you end up not surviving from.
Yeah, and there's a lot of, there's the thing that's really kind of hits me with that is the percentage of folks that really do have long-lasting effects. It's 3/4 of the folks are going to have something that they're going to be living with for a very long time. It's just, you can't just walk away from it and think, oh well, that was Tuesday. It's not
right. Exactly. Oh yeah, exactly. You do end up, whether you physically improve, but you may have some cognitive issues remaining, or vice versa. So there's some lingering effect that you end up having for a lifetime. And speaking of that, so what happens then? You have a stroke and you've survived. Now you have certain impairments. It changes not only your life, but your caregivers' lives, your kids, your parents, whoever it may be. And right here, daily living skills. Yep. Brushing your teeth, being able to get in and out of bed. Everything that you do from day to day, from the time you wake up in the morning till the time you get to bed, all of that changes.
Right.
All of that changes, right here, one-sided neglect. A lot of times people have, one of the symptoms for a stroke is neglect, where you don't recognize your one side of the extremity. Say it's your left side. You don't recognize anything on your left side. Not only your vision is there, but your brain's not able to recognize that there's anything on that left side. So a lot of cueing is required, where as a therapist, I'll say, hey, turn your head to the left and recognize what's going on. Recognize that there's someone standing there, there's an arm there, there's a leg there. So that happens, and that's really scary, where you don't even know that you have an arm. Or you can't feel it. If you feel it, you touch it, you can't recognize it. You just don't know what it is, and that's really important. That's just really, that's tough too, as a caregiver, that you don't know what that means. How do you work with the person who has this, right?
Right.
A lot of changes and a lot of education needs to happen.
I mean, there's just a lot I mean, you think about it, you're right, from the time you get up in the morning to the time you go to bed at night, I mean, just think about the effort that is an all day, it's just an all day sucker. I mean, just getting dressed. And if you,
Right.
especially if the stroke is on your dominant, it affects the dominant side of your body, so if you're
Yeah.
left-handed and I have a right-handed, if I have a right side stroke and I'm left-handed, it's a whole nother, snapping a bra together is going to be a whole nother story.
Oh yeah, absolutely. And we talked about aphasia. So say someone ends up having communication problems, so now they're not able to tell you how they're feeling. They're not able to tell you that they have pain. They're not able to tell you that they want to go to the bathroom.
Right.
And then on top of that, they have some sort of a neglect on their dominant side, and they have some behavioral issues. How do you deal with all of this?
And
So
that's that emotional thing, the depression
absolutely.
that can happen.
Yeah, and yep, depression sets in real quick if not saying that if none of this is addressed that you're going to have depression, but think of it as loss of independence for this person, recovering from a stroke. You've lost your independence, your ability to talk, your ability to let your thoughts be known, your ability to just do things.
And the frustration has got to be huge. I imagine, especially with aphasia. I mean, not I think with a lot of the symptoms, but especially when you know the words you want to say and you just can't get them to come out of your mouth, and you can't communicate it. And that can certainly lead to depression. And I think it helps for caregivers to understand sort of at the outset that these are the things that you can expect and that you need to be looking for, and we're going to need to put some coping mechanisms in place and some tricks and some support systems in order to be able to kind of address these issues rather than have them come up and just hit us in the face. I mean,
yep. And it's so important for caregivers to have their respite too, because
right.
now say this happened last week, and now you're home dealing with all of these issues here, and then you're trying to do the best. You're trying to do the best to help your spouse, or whoever it may be, while dealing with communication and behavior and depression and all of that. And then you caregivers also suffer. They also end up having depression. I forget what the statistics were, but there are large portions of caregivers that end up getting depression themselves because it's a burden of care that they have to deal with, learning new things. Their entire lifestyles change, if their spouse was the more independent person in the relationship, doing everything from bills to driving, and now you're responsible for not only your household work and all of that, but now the person themselves.
Well, and there's a loss there, and it's not necessarily addressed to that caregiver where it, because it's the person you're not the person that has had a stroke, even though there is a loss for all those people in that circle. Mm-hmm. And I know you have sexuality and intimacy. There's a whole nother set of things that are impacted, and they're going to directly impact your day-to-day life with your spouse. So there's, I think that there's a gap back to those indirect costs.
Yep.
Too,
I had a client that I saw for about 3 years, on and off. It was a post-stroke, and so a lot of the things that he had were listed right on here. His behavior changed, very aggressive, and it's not something that he could control. It was just what was affected. Right. He was also depressive. He had one-sided neglect, plus he had communication problems. So he was working with speech therapy as well, and he, like we talked about, he knew what he wanted to say, but the words weren't coming out. And so the speech therapist helped him set up with a device that he can, punch in some words and some pictures that when the device would kind of speak to us and say this is what he was wanted. But even using the device was really difficult because the stroke happened on affected his dominant side. So now coordinating with his left side how to do things was really frustrating for him. He would literally take the device and smack it on the table, and just out of frustration that it would take him so long to say, I want a drink of water.
Right.
And so, and then the wife would get really frustrated at his frustration because she's
Right,
trying to tell him like, don't get frustrated, but it's like telling someone to relax when they're angry.
right,
You
right,
just made them angrier.
right.
And so their lifestyle changed completely. And he, as his therapist, he actually told me one time, he's like, I want to be intimate with my wife, but he's like, I physically cannot. And just for him to tell me that took about 2 or 3 weeks. And I don't mean that the courage it took, the process it took for him to tell me. How is he going to tell me? Because on the device said nothing about, sexuality or intimacy or anything
Right.
like that. He had to learn how to write. And he just wrote, the 3 letters and kind of told me his wife and him. And I understood what he was trying to say.
Mm-hmm.
And there's different strategies I can help out with in terms of like bed and positioning and all of that. And that's part of therapy.
Right, and but if you don't even know that if you don't even understand that there's somebody, there's so many layers to that. I mean, people understanding that that if you can finally communicate it, there are ways to help with that sort of thing. But if you don't even understand that there are ways to help, and then you're having trouble communicating it, and the person that could help you doesn't understand it yet,
Right.
you're right. It can take a very long time. So that 2 to 3 weeks just for him to get it out was after he had gotten up and known you and developed enough of a relationship
Yeah.
for him to feel close enough to you to mention it. Because it's not going to roll off the tongue of somebody.
No.
It's,
Yep.
you don't
And
do
it,
well in here.
and it makes a big difference on who's on the other side, right? So here's
Right.
me, I'm a young woman trying to talk to someone who's elderly and trying to get them to open up to let me know what all they're feeling, and talking about, wanting to be intimate with your spouse. A lot of times with the older, and I'll say males, they'll have a harder time telling someone like me, like younger person, how they feel. They're just, their privacy, of course, have to respect their privacy and just the way they're raised and brought up, and you have to respect that. But they get that courage because now they're realizing how much is affecting their relationship with their spouse.
Right.
So they're just trying so hard to find a solution
Mm-hmm.
through it all. So it's tough. Lifestyle changes dramatically for everyone.
Right.
But there's therapy. There's different types of therapies that can address a lot of these issues. So we have physical therapy, occupational therapy, speech, and recreational. These are just the 4, but there's, some people may end up going to a psychologist or a psychiatrist. There's an
Right.
arts therapy, music therapy. There's a whole slew of, we actually had a music therapist in my old job that I was working at. This specific patient that we were talking about, she came in and was using a metronome system, rhythmic, that for him to be able to learn his gait pattern.
Oh, wow. What a
We
great
worked
idea.
alongside a physical therapist and myself to be able to get him to step, correctly, and also using that metronome system for his verbal output. So, it's just not PT and OT and speech, or everything else that's involved. And what we'll do is I want to let you know about what the differences are between PT and OT. Here's a good photo I like to use. Occupational therapy is your occupation, your day-to-day activities that you do from the time you wake up till the time you go to bed. Occupation, some people get confused when they think occupation is work. Yes, that is a part of what we do. Right. There are occupational therapists that are trained to help with, getting back to work. That's a whole different area. In a general sense, occupational therapy is, like I said, your day-to-day activities, from being able to write, how to hold a pencil, how to form letters, working on fine motor skills, how to use adaptive devices to brush your hair, comb your hair, brush your teeth, how to make meals, all of your tasks that how are you going to do this one-handed?
Yeah, and I like to think of occupational therapy as what occupies your time.
Yes.
What occupies your time? What occupies your day?
That's actually really good, that the way you described it. I've never heard anyone say that, and that's excellent. I think I am going to use that.
Yeah, because it's really, when you talk about, how do you occupy your day?
Mm-hmm. Yep. Okay, so post-stroke, what'll happen is typically, so you're at the hospital, you end up getting therapy. You should get therapy at the hospital. Sometimes, just depending on circumstances, but you get therapy at the hospital, then you get discharged, and you may get therapy at home as well. And then you go to an outpatient clinic. So all different types of therapy is involved as well, different locations. And what we look at and when we do our assessments is very, very thorough. It's you just from head to toe. We look at motor function. That's your functional use of your extremities, your arm and leg in daily use. You look at your coordination, your gross motor coordination, your fine motor coordination. Are you able to bring your hand to your mouth, right? Let's say your dominant side gets affected. Now you're using your non-dominant side, just that coordination of getting the spoon, from your hand to your mouth.
Right.
Things like that. We look at strength. We do what's called a manual muscle test, and we grade, we use that test to grade your muscle strength. Not just your arms and your legs, but your grasp, your grip. We have devices that check all of that. Your range of motion. Your range of motion pretty much means how well you're able to move, to what degree you're able to move your extremities. Full range of motion. When you're doing, your shoulders will look like this. A lot of times with stroke, you're not able to really, flex or extend all the way. There's different types of range of motion. Active range of motion is me doing this by myself. Passive range of motion would be me taking your arm and helping it move. Okay, and then there's active assist. A lot of times with stroke, one of the exercises that, that we encourage survivors to do themselves is exercises where you hold your hands together like this one way, and you use your working extremity to help pull the other one, use up and down. Or, you hold this way. So whatever the movement is required, pretty much actively assisting your extremity for the other one to move.
So you're sort of the passive, but you're doing it yourself.
Yeah. So passive is when someone else is doing it. Actively is when you're using your working extremity to help move the other one.
Right.
Yep. And we also look at tone. Tone is, you'll notice a lot of times when people have stroke, that's one of the first physical, visual symptoms that you'll notice. Either the extremity is really flaccid, just, no tone to it at all. The decreased tone, increased tone, or they're contracted. If someone has an increased tone and they're kind of in an extended position, it's really hard to, flex. So you'll notice a lot of that resistance. So tone is also what we check for pain. Sensation. A lot of times people are not able to, they lose their sense of sensation. Light touch, even if you just go like this, they may not feel that. They may not be able to tell between hot and cold temperatures either, which is really important because say they're not severely impaired, they're able to take a shower on their own, but you don't realize that they've lost their sense of temperature. And if they're out there taking a shower in super hot water, they can get burnt.
They can.
So
another thing with sensation is if somebody's having, they're not moving as much and they're spending a lot of time either sitting or in bed, and they don't have a lack of sensation. They have a lack of sensation. You have to start to worry about your skin breaking down and what bed sores or decubiti. I mean, that's a huge issue if you're not. So that's, making sure that you're positioning, making sure that you're paying attention to those things. And as a caregiver, if you are helping, if you're helping your loved one, with morning care and that sort of thing, is to be able to really check and to do it yourself if you can, to check to make sure that everything's okay.
Mm-hmm. Yep. We always, encourage. So say, like we said, if someone has difficulty communicating and you have difficulty moving because now only one side of one part of your body is working, caregiver education, along with providing the therapy to the client, caregiver education is like our second goal. Educate the caregiver, this is how you can communicate, different strategies, compensatory strategies to help you communicate, with your loved one. Make sure you help them change positions because they may not be able to tell you that, their bottom's hurting and they may be developing a bed sore. And if that turns into like a stage 4, then it's just, another problem that you don't want to worry about at that stage. So the edema and going back to motor function. So when we do an assessment post-stroke, It's really thorough, and it has to be, because like we said, there's so many things that can happen that we have to check on. That way we can educate the client and educate the caregivers to be like, hey, this look out for this, look out for the fact that they may not be able to, feel hot and cold, or they may not be able to feel pain, hot and light touch. So if they get hurt, they may not know that they're bleeding from their skin or something like that. So evaluations, both OT and PT kind of go through this entire matrix and more to do, a thorough summary of the evaluation.
Yeah, that's one of the things that I think was really key when you and I talked before, was the idea that OT and PT really work not that all of them don't, but there's got to be a huge amount of overlap where kind of PT ends and OT starts, and you're moving back between all of the disciplines.
Right.
But because OT and PT really have to do with a lot of the physical muscles too, I think that there's, you're not going to be able, if you don't have physical therapy to help with your large muscles and your you're going to have trouble with the OT.
And you're right. With the therapist, we all work together. We have to work together,
right? Because
our end goal is for our patient to be as independent as possible,
right.
And that's with or without assistive devices, with caregiver intervention, whatever it may be, compensatory strategies. But the goal is to kind of use all of that to make them as independent as they can be,
right,
with their impairments.
Yeah. So if you have somebody that's been working with, if you have the speech therapist that's been working and they figured out, a way to be able to more fully communicate, well, that's absolutely going to help the OT and the PT.
Right. And we do that. I do that right now, actually. So I work alongside PT and speech at the same time. We have a client that, the PT will put them on this unweighted treadmill machine that we have to help her walk. So while she's on that treadmill machine, I'll put a mirror in front of her, and she's holding on one side, and she's like functionally reaching on other to grab something. And while she's doing that, the speech therapist is also there prompting her to verbalize like red or colors or whatever it may be. So the three of us work together to achieve one goal.
That's really
and it goes on with every clinic. We try to work together as much as possible.
Right.
If my goal is for my patient to, make it to the bathroom, get up from the wheelchair and walk and go to the bathroom, sit down on the toilet, I cannot achieve that if the PT is not working on their gait and their walking.
Right.
So, So when we do our assessment, going back to the slide, when we do our assessment, we set up goals based on all that any of the deficits that we find. We set up goals and we ask the client what their goals are too. What do you want to achieve from therapy? These are all the things we can work on and we will work on, but what do you really want to do? Their goal may not be to brush their teeth. That's the least of their priorities. What they want to do maybe is to be able to dress themselves, or make it to the bathroom, like I said.
That's a really good thing to talk about, is the fact that you're right. To ask the patient, or the client, involve them in what their goals are, because I imagine people might be very surprised to find out that what I might consider a primary thing that I would want to take care of first, somebody might not. It might be being able to take a shower.
Right.
And it might be, or it might be able to get to the bathroom by myself, or right.
Yeah, and that's exactly right. Our documentation systems, we have a section that literally says patient goals. Mm-hmm. And my job is to ask you, what is your goal? Mm-hmm. These are all the things that we found, and these are all the things that we can work on, but what do you want to work on? Because otherwise the therapy is kind of moot, right? Why am I going to work on something where I think is right for you when you don't really, that's not your goal?
Right, absolutely. It's not, you don't have any, you're not vested in it, you don't have any agency. Right.
So when we develop our goals, we really get the patient, the caregivers, everyone involved, and then we set up our goals, and then we work, like we said, work together with the music therapist, the speech therapist, everyone together to achieve those goals. Mm-hmm. And intervention. So what are some of the interventions that, there's a lot of different things that OTPT speech can do to help with the recovery process. And there's a whole list that I've put out here, but the main thing that I want to really hone on is that rehabilitation strategies, they're required to be repetitive, they're required to be intensive and task specific. And what that means is any of these, say mental imagery, you know, mental imagery is where we really have someone really focus on say I want you to be able to move your arm to pick up a can, you know, or a bottle of water. You want to be able to close your eyes and mentally act that out in your head.
Right.
You picture that in your head before you perform that activity. And that, and you know, it's not that you just do it and you think about that in your head and you should be able to do it. It's repetitive. So you're trying to fire your neurons, you're trying to get your brain to send the signals and fire the neurons to perform that act, but without being able to understand what movement's required, you may not be able to do it. So it has to be repetitive. You have to keep doing that, you know. So if I use that type of form of therapy, mental imagery, I have them doing that before every task. If I say, you know, we're going to go from here to the bathroom, well, I want you to picture that in your head before we do it. Okay, now you're going to pull down your pants to be able to sit down on the toilet. Picture in your head before we do it. So it has to be a repetitive process with any of this. Joint protection support, you know, wearing a brace or a splint. You can't just wear it for a day and hope that and think that it's going to work. It has to be an everyday, and there's a schedule that we teach, you know, how long to wear it for, what to look out for skin redness and whatnot, range of motion.
One of the things that I'm really kind of do this with all of my caregiver conversations. I just randomly interrupt, so I apologize. But I was thinking, you know, what I think of in my head when you talk about things having to be repetitive, is I had somebody once talk to me about you know, forming those synapses and those neurons and those pathways in our brain. It's sort of like when I was going to school, I would walk to school and there was a path that we would cut through. And a lot of the kids that would cut through this path, and it sort of cut off a kind of a corner of like it was a little teeny tiny little, it wasn't really even a wooded area, but it was just on the corner of somebody's yard. And there was a path that got worn through where the grass got worn down. And I would notice that, you know, by May, it would be really worn down, and we would come back in September, and that path wouldn't be there as much anymore. But, you know, so they're repetitive. It makes that pathway stronger every time you use it.
Exactly. And that's what I was going to, yep. So the repetitive, the intensive, and task specific therapy, the strategies, it's important. They're required for neuroplasticity to produce recovery. Like you said, exactly that, you know. And it's also reported, I think this was at the Journal of Physical and Medical Education, I think it's called. It's reported that when therapy begins within 16 hours to 6 months post-stroke. So 16 hours to 6 months post-stroke. If you begin your therapy during that time, there's significant improvement in your ADL performance with the augmented exercise therapy.
Absolutely.
Yeah, and what we mean by task-specific training, I'll quickly go through some of these. Task-specific is kind of what we talked about. What do we want to do? So say our goal is to be able to put on your pants. Okay, so that's a task and it's specific to what you want to do. Well, what's all required? We break down the activity to the T. So in order for me to put on my pair of pants, one, I need to pair of pants. Two, I need to figure out the orientation. You'll notice a lot of times that, you know, the pants are upside down, they're inside out, and you working with one hand. How do you do all of this? Okay, and the second thing as well, now you're working with one arm, working with one leg. You may be sitting in a wheelchair. How do you extend your leg to be able to bend down enough to put that leg in? Can you even bend down that far? Do you have the back control to be able to come back up again? Right. If you can't reach down there because now you have a lot of tone, you have increased tone, you can't extend or flex your leg, you cannot possibly get that leg, your, you know, pant leg on. So then we also, should I put that on here? assistive devices. You may need a dressing stick. You may need a reacher, you know, the grabbers that help you with all of that. So it's task specific. You know, it's just not, we're not just working, the PT's not working on their legs just because. Your goal is for them to be able to walk, for them to be able to bend their knee and have that proper gait pattern. Another one I like using this therapy is called constraint induced movement therapy. And what that does is you pretty much isolate one extremity to force the other extremity to produce a movement. So you, sometimes people put on a glove or a sling. So on your working extremity, you constrain that, you strap that into the side of your body so you cannot move it. And then I say, all right, go ahead and pick up that cup. Now your non-working extremity, won't be able to move, but that working extremity naturally is going to want to go ahead and try to go for that cup. So it forces the other extremity to make that movement. You know, and they're just synapses, the connections that's made between sending you know signals from your brain to make that motor output, and that's what it works. And that has to be repetitive. There has to be an everyday intensive therapy. Okay, so yeah, the other therapy that I really like to talk about is mirror therapy. But quickly, before we get into that, I want to talk about the range of motion and strength training too. So you know, your range of motion is lost, especially if you have increased or decreased tone in part of that, and your strength too. So we do a lot of that. We also do self-care training with assistive devices and assistive equipment and compensatory strategies. What all that means is you'll notice dressing sticks, reachers, sock aids, or you're not able to put your socks on with one-handed technique. We teach you how to use that sock aid to put that sock on there and then put it on the floor and put that on. Home modification. If you're in a wheelchair now and you had stairs to get into your house, you may need a ramp to get in. You had a tub. How are you getting into a tub now? So, you know, you can get an assistive device or an equipment transfer tub bench. You get
and that's where I'm gonna make a little pitch for Sunflower House. Yep. We have, and you know, a lot of times insurances will cover these assistive devices, but there are times where you know, you might just want something temporarily, or there might be something, you know, that you can come over, call Sunflower House, and we have durable medical equipment. So we have wheelchairs, and we have walkers and seated walkers and transfer benches and shower chairs and bedside commodes. And please give us a call. Give me a call. My name is Beth. And if you leave a message, I will get back to you. My phone number is 452-4341. That's 321-452-4341 to see about any of that. Also, Aging Matters in Brevard does a huge amount of home modifications. So we can have somebody come out and help with ramps and grab bars and wheelchair access if you need to be able to have a little T ramp that goes from maybe your back patio or your garage into your kitchen. It might not be a huge ramp, but you might need a little bit of something. So those kinds of things we can work with. So give us a call.
Yep. And I'm so glad that you guys provide that type of resource, because, you know, sometimes you do come home from the hospital with certain equipment that they're going to give you, but a lot of times you just need other things at home. You know, the grab bars are not what's covered by insurance. Right. So grab bars, you're going to, you know, you may think, okay, I'm going to need a grab bar in the bathroom. Mm-hmm. You may not realize that, you know, you're going to need a grab bar when you're going from your garage inside. You may have a little step up. Mm-hmm. Grab bars next to your toilet, like you said, ramp. You know, a lot. What we've also done is someone would love gardening, or they like sitting out in their patio to watch, you know, in their backyard, but they can't get there because now they got a little step. So a ramp. So when therapists, OTs do home modification assessments, they literally, just like as if we were doing an assessment on the person, the home modification assessment is from your front door. Everything inside and outside, your entire property is being assessed, right, with modifications that you may or may not need, you know, especially based on, like we said, we involve the caregivers and the patient. What is it that you really want to do? If you're hobby is to sit outside and watch the birds, or, you know, fill your bird feeder. Well, how are you going to get there now? So, you know, like you said, resources that you guys provide from Sunflower House and Aging Matters is so great, because otherwise it becomes really expensive. Aside from all the medical costs and everything, things become really expensive to try to get purchased on your own. Hospital bed,
I mean,
and
your insurance might cover a wheelchair, but it might not also cover a transport wheelchair, which is a different thing.
right.
So if you're going to need, you know, you might have one of those big, huge wheelchairs with the big wheels for in your house, but you know that can get difficult to slip in and out of the trunk of the car. And so a transport wheelchair that's lighter and is meant to push somebody, you know, your caregiver might really be a help. Right. And is your insurance going to cover both kinds of wheelchairs? Well, you know, maybe not. You know, so.
Yeah. And like I said, I'm so thankful for you guys to have that, you know, resource available, because we need that. The other one, so I want to get back to this one, mirror therapy. I've done a research on mirror therapy many years ago, and I actually love using that type of therapy. Post-stroke patients. Also, mirror therapy is also used for amputees. And I'll tell you exactly what that is. So before we get into that, here's what we talked about earlier with PT intervention. So if you go back to OT interventions and PT interventions, you see some of them kind of, they're the same. Contracture management, strength training, mirror therapy. And like we said, is because we work together. We have different goals, because like you said, the PT is a bigger muscle, you know, lower body, that you kind of want to think about that. And whereas OT is more occupation-based, a functional-based therapy. So a PT can get you to walk. They can get you to walk from, you know, longer distances, but now how are you going to get from your bedroom to your bathroom, and how are you going to sit down? That's your task specific, and that's where OT comes into play. So we do work together. A lot of this is very, you know, they work on your positioning. If you've lost strength on one side of your body, that means also your spinal cord, right? So now you'll notice people will be leaning on one side, one or the other, because lack of muscle strength over there. They work on your balance, orthotic management, whether you need a brace. A lot of times with our foot, you'll end up getting a foot drop, right? Because the muscles are weak and you don't have the strength there anymore. So they help you with the brace that you can put in your shoe to keep your, you know, foot in a proper positioning. They also do a lot of the constrained movement therapy for lower extremity, and mirror therapy as well for lower extremity. So here's mirror therapy. Mirror therapy, it was founded many years ago, I believe by an Indian doctor. Not sure where he was, but he came with this approach, and he did a lot of research from over many years, and he found it to be very, very effective. Let me just pull something up. Okay, so mirror therapy can be used even in completely plegic stroke survivors. So, you know, as it uses visual stimuli for producing a desired response in the affected limb. Okay? It's studied to have effects not on just motor impairments, but also on sensation, visuospatial neglect, and pain after stroke. And I also want to add on that it's not just pain after stroke. If you're working with an amputee, it's pain. You know, when they have phantom limb pain, mirror therapy helps greatly with that. So the way mirror therapy works is it's post-stroke mirror therapy. You know, it's up to 1 to 8 weeks of intensive mirror therapy. This is what it looks like. So the idea is, so this is your unaffected hand over here, and this is your affected hand. Mirror therapy is pretty much you take a mirror and you put it in between your extremity, your left versus your right. Okay. So in this gentleman here, can you see my cursor if I'm moving it? Okay, perfect. So this portion, this arm right here, that's his left, and this is his right. Okay, so we'll kind of address it that way. His left is his affected arm, and his, whoops, where did we go? There we go. His right is his unaffected hand. So you take the mirror and you put it in between the two. So pretty much you're covering your left affected arm and hand into the box. So you cannot see that. On the other side of the box is this mirror over here. And then so you put your unaffected, your working hand in front of that mirror. And then I'll ask you to do a task like this. See, this is the working hand. This is the mirror, and the one that's hidden over here, that's the non-working. And so and then, the therapist will ask the person to produce a movement, make a fist, open and close, or move your hand up and down, or slide it back and forth, whatever it is. While you're producing this movement, you're required to look in the mirror. So when even you and I, when we look at this image here, when we look at that image, it looks like he has his both left and right hand.
Right.
And so when you look, so the therapy involves, it's about an hour-long therapy. You sit there and you kind of do all sorts of movements. One hand is in the box, one hand is outside. The working one is outside, and you look in the mirror as you produce this movement. So as I'm producing this movement, my brain is thinking, hey, look, my non-working hand is moving. You're literally trying to trick your brain into thinking that your affected arm is making the movement. And this is a repetitive task, 1 to 8 weeks of doing, practicing this type of therapy and causing some sort of a movement. After this therapy, we spend about 45 minutes or 45 minutes or so doing this. And then you go ahead and I remove the box, and this is something that I do on my own. I go ahead and have them put both their hands on the table, and now you visualize both. Now you're looking at it without the mirror, and then I want you to try to do the same movement. Right, so now that you've tricked your brain for 45 minutes thinking that it's able to do this, and now you take the mirror out and you look at your actual arm and you're trying to produce that movement. And there's studies that show that there is improvement with this. So in contrast to like the varied therapy approaches that we talked about in the previous slides, which require some degree of a voluntary movement, mirror therapy can be used even in, like I said, completely plegic or severely pleuritic stroke survivors, because, like I said, it uses visual rather than your somatosensory stimuli for producing this response that we're asking for.
How really strange the brain is.
Yeah.
So I mean, it's just amazing, because I've seen, like, literally like bar tricks where you do that sort of thing, where you're putting a feather on somebody's hand and you're doing it on their affected hand, but you think on their non-affected hand, you do it on their regular hand, and you swear to God they're doing it on the other hand.
Right. Yep. Yeah. It's an illusion of movement in your affected hand. And like I said, I wish I had another photo for you, but you can also use this on the lower extremity. So in the lower extremity, you need a larger mirror, long mirror, and you just kind of place that in between the legs, and then you have like someone do knee flexion, extension, any ankle movements while you're looking in the mirror and thinking that your affected side, you're producing that illusion that your affected side is making the movement. So again, repetitive, intensive, daily exercise, daily therapy in order to produce some sort of a result. So I love this. I've used mirror therapy a lot of times, and I've seen results. I've seen minor improvements, but they're improvements. If your extremity is paralyzed and you have any sort of movement, it's, even if you're able to give a thumbs up or move your hands up and down to be able to at least just grasp something, it's big.
It's huge.
It's huge. Right. So yeah, this is one of my favorite ones.
I think it's really cool. It's really neat.
So the other services that types of recovery services, I brushed on this earlier. So, I said you get rehabilitation in the hospital. While you're at the hospital recovering from the stroke, you'll have therapists come in and trying to get you out of bed, trying to get you to move as soon as possible. So there's a rehab unit in the hospital, then you have the therapy. If they think that you may need a little more intensive therapy, you can go to an inpatient rehab facility, and you recover enough that you're able to go home. Now you're home, but you have to adjust to your new home environment. So you can get home health therapies. Therapists will come to you in your home and you don't have to modify anything, because now you're home. You can actually use your home environment, the items at home, your actual bed, to practice what you've learned in rehab in the hospital or inpatient rehab to employ these strategies. Yeah. And then, you also have outpatient therapy, long-term care, and community-based programs. I want to go back on outpatient therapy. Outpatient therapy is when, you'll go to a clinic to get your therapy. In Brevard, we have outpatient therapy, but therapists can come to your home to provide this therapy. And that's kind of what I do. I have a mobile therapy service where, it's an outpatient service, but it's mobile. It's a concierge type of service where we go wherever you are. The difference, the difference between the home health and outpatient therapy, it's billed differently. Say you have Medicare Part A will cover home health, Part B will cover outpatient therapy. It's billed differently. The service is the same, right? Not a lot of people do the type of service that I do, in the sense where I go to the home to provide outpatient. You don't have to worry about going to a clinic. You don't have to worry about driving or looking for directions. So you're at home, and you get continuity of home health, post-home health therapy. And we work with a lot of the home health therapists here, in the sense that, some stroke survivors, they get the therapy at home, OT and PT, and then they're discharged, but they're not just quite ready to be out in a clinic, especially now with COVID. So we follow up as an outpatient therapy provider into the home. So that's an option for people to have, to know that resource is available.
It's great to know.
And other resources or community resources, they're, aside from what's available online, which is a lot, and these right here on the side, just move here, are a lot of the associations that you can, like I said, Google, and they will give you, there's so much, patient caregiver education sections on there, and there's so much information that you can just download and keep for yourself. Lots of resources. Stroke Recovery Foundation is one, American Stroke Association, the PHASA Association, and there's a National Stroke Association, Hope After Stroke. Locally, we have neurologists. We have a lot of adaptive sports programs. And I want to talk about that. And there's someone, I believe they're in Indian River County, I believe they're a therapist, and they came up with these adaptive wheelchairs that can go on the beach.
Yeah.
So we live on the beach side. We love going on the beach, right? So a lot of our clients are, they have condos on the beach side. They used to go walking every day, but now they can't. Regular wheelchairs won't work on the beach unless if there's, they've got the footpath, the wooden path along the way. Most beaches don't have that. Right. So these I want to call them therapists because they may not be, but I'll just call them therapists. They came up with this wheelchair with these like rigged wheels, these big thick wheels that will work really well on the beach.
That's great.
I can send you the link for that too, to use as a resource. So now they're providing these to people in the community to use them. You don't have to be a stroke survivor. It could be anyone. You're just debilitated.
I would love to have that link. I have a friend of mine, and he and his wife have an adult child who has a severe cerebral palsy. And they come over to Cocoa once a year to a timeshare. And I'm not sure that they have that. So do you know if I'm putting on the spot here, send me the information, because I'd love to know whether or not they may be available for short-term rental kind of a thing.
I'm not sure. I'll have to look up that information and send it to you. Yeah. I do know they are on Facebook, so I'll find that out and I'll share that with you. I think it's great service that they're doing. Other things I'm not sure locally, but I've heard in the news that people will go skydiving. You can there's adaptive sports programs available throughout the country, and the things that people are able to technologists, they'll come up with all sorts of devices for you to be able to use to participate. You'll have we had Junior Olympics last year? And you have wheelchair sports all around that you can participate in. In Brevard, we do have the Aging and Disability Services. We have the Brevard County Stroke Survivors Group. They're in Cocoa Beach, and that's the address. We also have the Brevard Health Alliance. We have the Melbourne Regional Medical Center, and they have a whole stroke program. I'm not sure if they're doing that right now because of COVID, but they do have stroke. What do you call it? They have the support groups. They have a lot of support groups. They have the Parkinson's support group. They have stroke survivor support group, caregiver support groups. And then we also have the Heart Center at Holmes Regional. So there's a lot just in our county that, you can seek out. You're not alone. I love to tell the caregivers, and I hope that they understand that you're not alone. You may feel like the world is ending. Everything is on their shoulders to be now taking care of their house, their spouse, their other family members, being strong themselves. But there are other people that have gone through this. There are going through this. Other people are just learning about it. So there's help available, aside from therapy, and the therapist, they'll do the best they can to help your loved ones stay safe at home and keep your house safe for them.
Right.
But aside from that, there's associations that they have a wealth of knowledge. Aging Matters in Brevard, you guys have a lot of resources. Sunflower House, when you guys do provide the durable medical equipment. So there's a lot of resources out there. So just seek out, and seek out help. There's people willing to help, and there's friendly people here. Yeah. So I hope all of that helped, all the information helped. It's a broad topic, and there's a lot that, is still out there that we can't cover, but in the general sense of recognizing the symptoms, knowing ways that you can prevent stroke, changing your lifestyle a little bit, diet and exercise and medication, talking to your doctor, and knowing that there's therapy available with, in any setting that you want. Thank you for having me.
Well, and thank you very much. And again, Jital Patel has her company is called Coastal Occupational Therapy, and it is right here in Brevard County, so it's local. So here's her number. I'm sure that you can reach out to her by email or on phone if you want more information about her services. I think it's really cool if you have the ability to be able to do it as a mobile thing. Yeah, nice. Even if it's just an intermediate between the time that they can drive and when they first when they're no longer doing the home therapy, and yet they can't quite get out there and drive, or they don't have the support system around them to get them to outpatient.
Right.
I think that's really cool.
Yep. And we also have a physical therapist and a speech therapist. So just, I know the name says occupational therapy. We do have OTPT and speech available. And like you said, it's a mobile service. So we'll come to you wherever you need. And speaking of the driving, we do also do driver evaluations. I just did one the other day. And on that topic where, there are driving rehab available post-stroke. Stroke survivors, doesn't mean that you can't drive anymore.
Right.
There's, adaptive vans, adaptive cars that are available. We teach you techniques on how to get back behind the wheel. Granted, depending on the impairments, but we work with all of that. We do, we start off with the clinical evaluation. It's about 1.5 hours to 2 hours long. We really do a thorough evaluation. If it deems necessary that you need to go to DMV and take a driving test, we recommend that. We get the doctor and the family members, caregivers involved to get a plan of care going. And, if your goal is to start driving again post-stroke, just so you can go to an outpatient clinic, we can help you with that too.
Well, yeah, it's just the, just the sense of independence that comes with the ability to drive. That's huge.
Right.
I thank you so much, Jital. It's been a wonderful caregiver conversation today. I look forward to being able to have additional conversations later on. I hope to see you again. And I hope that at some point you'll be able to come and do this kind of presentation right at Sunflower House whenever we can get past COVID and we can get back to something that looks like, not 2020.
Yeah, absolutely. I would love that. And thank you for having me. I hope this was informative.
Thank you so much. I appreciate it.